of everybody's time. Um, so I think we'll get started. Hi to Tony, Eric, Blair. Hi, Paul. Hi, Don. Tony, Eric, Blair, just introduce myself because Paul and Don know who I am. I'm Brad Walters. I'm one of the attending physicians at Beaumont Royal Oak. Beaumont Royal Oak had a fairly significant surge of COVID patients. I'm not sure if we saw more than any other hospital, but we were up there. And being in Oakland County, sort of the epicenter of things. Can everybody hear me?
Yes.
Okay. All right. So I'm part of the William Beaumont Hospital Department of Emergency Medicine at Royal Oak. I'm also faculty at Oakland University William Beaumont School of Medicine. All right, Maddie. I have no disclosures. My goal in life is to be the person my dog Winston Churchill thinks I am, and he's. I've already put him to sleep with this lecture. So why is this important? Well, the airway management is one of my passions, and certainly this novel coronavirus has been a marked challenge. The pneumonia and respiratory decompensation seems to be somewhat unique and not the usual bacterial viral pneumonias that we usually see, and certainly a different sort of ARDS. It's rapidly changing. It seems like what we learn on Monday is debunked on Tuesday and then reinstated on Wednesday. We're seeing both initial infections right now, but interestingly enough, we are now starting to see patients who were weeks or sometimes months in the hospital. They were COVID positive, and now they're returning to the emergency department with similar symptoms. I wish I could tell you that if they test positive, that this is a new reinfection or not, but I really can't. Will there be a second wave? Well, Anthony Fauci of the CDC says we haven't even finished the first wave, so why talk about a second wave? But maybe right now here in the state of Michigan, because things have kind of damped down, maybe we should use this time to prepare and use lessons. So who's our risk patients coming in with a COVID infection that might go on to respiratory decompensation? Well, the usual risk factors, obese patients, folks like Paul and I who are old, comorbidities, the usual ones, diabetes, heart, lung, kidney, and the immunocompromised patients. It's somewhat similar in the pediatric patient, the younger infants, and patients with congenital problems like congenital heart disease, chronic lung disease, vent-dependent kids, neuromuscular disease, and of course immunocompromised, and just to throw things in, the chronic kidney disease. We're not seeing very many of these patients. Children tend to do a little bit better, but the kids who get sick with COVID get sick rapidly and really fall hard. Predictors of respiratory decompensation, and this is something we need to think about, particularly as we're beginning to see patients return to the emergency department, is do they have a venous thromboembolus and have they thrown a PE? We know that there is a COVID-associated coagulopathy. It is not a DIC. And while it might not be necessarily applicable to the emergency department, Middledorf's data has shown within a week about 10% of these patients develop VTEs, going up to 25% by day 21. So if I'm seeing a patient, 2 to 3 weeks out, and again, they're coming in with shortness of breath, I'm worried about them decompensated. I'm very worried about them having a pulmonary embolus. Some predictors of embolus from Levitt and Helms, a very elevated D-dimer, certainly more marked in patients who died. We know that this is not a DIC picture because fibrinogen and platelets are typically normal. We do see a elevation in clotting factor times PTT and PT. Look at the seconds and ignore the INR. And we know that a sustained D-dimer that's not going down in 1 week is a very high-risk indicator of VTE if you happen to have that data from a recent admission. One of the interesting things that has come out is blood type as a risk factor for respiratory problems. In a study of just shy of 2,000 patients in Italy and Spain, they found that the blood type A conferred increased risk. Exactly why we're not sure, and this was reported in June 17th in New England Journal of Medicine. They identified some loci on various genes. I'm not sure how I would apply this information in the emergency department, but I do know that about a week and a half ago, I had a patient who was COVID positive, had been, this was a return visit. They had already been discharged from the hospital. And I did just happen to go back and look to see if I had a type in screen. And in fact, I did. They were not blood type A, but it was just one part of my screening of trying to assess potential risk factors. Just because we're going to be talking about RSI, a really quick review: the 7 Ps of preparation, pre-oxygenation, pre-treatment, positioning, paralysis with induction, put your tube in the trachea and prove that it is there, and post-intubation management with ventilators. I'm not going to dwell on this very much. I'm going to assume everybody's relatively comfortable with RSI, but I just wanted to mention this. So, pre-oxygenation. We find, and I've stressed to my residents when I'm lecturing, pre-oxygenation is critical. It gives you the time to intubate without these patients decompensating. And the problem is it's often really, really difficult in the COVID patient. So our options are nasal cannula. You can crank that up to about 6 liters per minute, and then it starts getting uncomfortable. A non-rebreather mask, and if I'm about to intubate the patient, I'm running that at about 30 liters per minute with a nasal cannula underneath at 15 liters per minute. And that's just about an FiO2 of 100%. The non-rebreather alone, even at 30 liters per minute, draws in some room air, and you get a FiO2 of about 75%. High flow nasal cannula or high flow cold flow bubblers have been used. CPAP can be effective with a closed system and a viral filter. That's not possible with BiPAP, and we only have BiPAP available at Beaumont Hospital. And of course, if the patient needs it, a bag valve mask with both a viral filter, again, running at 30 liters per minute. And I want to emphasize, if you're bagging a patient and they've gotten to the point where you're bagging them in preparation, this is a 2-person job. Particularly in the COVID patient, we want to try to not splatter secretions around the room. So having one person getting a tight mask seal and lifting the mandible so that you get better airway clearance, and the other person squeezing the bag. Increasing oxygen requirements almost always heralds the need for intubation. One of the interesting effects of this whole thing is the need to protect the personnel who are doing the intubation. At Beaumont Hospital, we've adopted a 2-layer kind of system. The inner layer protecting the head with a surgical bond, an N95 or an N100, face shield to fully cover the face, isolation gown, and gloves. And an outer layer, we use the disposable surgical gown as if we were placing a central line, and again, a second set of gloves. Now, a lot of people have gone from an N95 to an N100, and we were just talking about in our resuscitation Zoom meeting today. One of the things about some of the N95s and certainly the N100s is it really covers your mouth and it muffles your voice. And we are finding people who are helping resuscitate the patient can't hear the physicians either at the head of the bed or running a code. So that's something to think about. I've included the Beaumont Hospital procedure for doffing and donning and intubating patients at the very end, and that's purely for your reference. The intubation equipment, medications, to a large extent, pretty much what we're used to. We sedate with etomidate, ketamine, propofol, or midazolam. Your choice. For the patient who is hypotensive, I particularly like ketamine. For steroid-dependent patients, your steroid-dependent COPD patient, for instance, I am avoiding etomidate. Whether the adrenal suppression is a factor or not, I really don't know, but I just use ketamine. Paralysis, I restrict it to two drugs. I know them well. Succinylcholine, 1.5 milligrams per kilogram, or rocuronium, 1 milligram per kilogram. Lidocaine is optional. The intubation equipment, this is a little bit of a change. I truly emphasize video laryngoscopy. Direct laryngoscopy is to be discouraged for obvious reasons of just contamination. For the Glidescope, which is the product we use, you need a rigid stylet and an endotracheal tube with a tube clamp. And this is what a tube clamp that we use. It's a nice plastic disposable clamp. It's got smooth jaws. You can also use a large hemostat or a Kelly with some rubber on it so that it doesn't injure the endotracheal tube. And the reason that this is important is you want to clamp the tube because you don't want secretions to splatter. Of course, the other things like Surgilube and 10 cc syringe and suction, and a back valve mask with a viral filter and end-tidal CO2. The goal is intubation with minimal exposure, and that's where meticulous oxygenation comes into play. The usual sequence, induction and sedation with your drug of choice, paralysis with your drug of choice. Personally, this is personal opinion only, I prefer rocuronium. I also often don't know what the kidney or potassium status is, and I like to keep the patients paralyzed for a little while so that I can get things set. One thing that's important in the usual rapid sequence intubation process, you'll give the sedative, you'll flush it, you'll wait a bit just to let that sedative set in. In the meantime, you're kind of positioning your patient, you're getting ready to do the actual intubation, and then you're pushing the paralytic. This is a little bit different in that you want to get the patient down hard and fast. I'm literally flushing the sedative, either etomidate or ketamine, with my paralytic, and then I'm flushing all of those. I'm trying to get the patient down in under a minute. Continued sedation is extremely important. Fentanyl infusions or intermittent fentanyl as an analgesic, propofol, and I'm using a little more dexmedetomidine in these patients. I find it has less hypotensive potential, though it can cause hypotension, than propofol. But keeping the patient deeply sedated is extremely important and allows for more effective ventilation. Actual intubation, Glidescope or other video laryngoscope, visualize your cords past the tube, remove your stylet, and immediately clamp with your little clamp here. At that point, you inflate the balloon, you note your depth of insertion, you attach the bag valve mask with viral filter and the end-tidal CO2 detector, and unclamp the endotracheal tube and start bagging the patient. At this point, you should see indications that you're through the cords and in the trachea. What you'll look for is chest rise, that your pulse ox is staying stable, the end-tidal CO2 changes color, the tube fogs with respirations, and you're going to recheck the depth of insertion. What we are not doing is using a stethoscope to listen, because again, that's one more piece of equipment that gets contaminated, and then you've got to clean it off. I don't think you actually need to listen to the lungs. I'm verifying the depth with a chest x-ray. I'm sure to look at it. And everything else tells me that the tube is in place. If the pulse ox is starting to fall and I don't see the tube fogging and the end-tidal CO2 detector isn't changing color, you're in the esophagus and you've got to back up and start all over again. Continued sedation, you've got a number of choices: propofol bolus and infusion, dexmedetomidine, which is also Precedex, fentanyl bolus and infusions, and ketamine infusions, or benzodiazepines, whatever you're comfortable with. Steroids, there's differing opinions. With the marked inflammatory surge with COVID, there are some experts that are talking about using stress doses of hydrocortisone if you've gotten to the point where you're intubating the patient. I'm going to talk about dexamethasone a little later, and we'll talk about that. And prone positioning has been shown to be of significant benefit, particularly in the patient who remain hypoxic despite ventilator assistance. I personally have not prone a patient. It's a little hard to do in the emergency department. However, I'm based on the data, I'm going to have a low threshold for doing that, and I'm going to talk about prone positioning before intubating the patient. The way I would do it is I would disconnect the patient from the ventilator after I've clamped the tube one more time. I would position the patient. I don't want to pull out the tube, and it's easy to do if you're connected to the ventilator, and then I clamp after I've reattached the ventilator. So some very interesting data that literally came out a week ago, and frankly, I read earlier today. I've been waiting for the a little bit more data to come out on this. This was an EMS study of 29 patients. I'm sorry, not an EMS study. This was 29 patients, 25 of which underwent prone positioning to see if they could improve their oxygenation and decrease the risk of intubation. And in fact, they were able to. In 19 patients, they improved the SpO2 to over 95%. Of the 6 who didn't, 5 were actually intubated. And that might suggest that maybe before and trying to stave off intubation, and some experts are saying try not to intubate patients with COVID, because some of the data shows mortalities up to 80%. And I'm not sure totally what that means. Does that mean 80% mortality because intubating patients indicates a group of patients who are very sick who would otherwise go on to die? Or is it a contributory factor that once you put these patients on the ventilator that they deteriorate? I don't think anybody really knows that yet, and the data is unclear. But if I'm trying to avoid intubation, I'm going to think about, strongly think about putting these patients prone and seeing if I can improve their oxygenation. And they did it for about an hour or more. So let's just talk about the challenges of the COVID lung. Intubating these patients, pretty much as you would any other patient, save for the fact you really have to protect your staff and yourself, all right? But the lung dynamics are markedly different, and this really influences how we ventilate the patient. Experts actually say don't intubate, as we mentioned. What they don't tell me is, what do I do with the patient who's deteriorating, who's becoming more hypoxic? What do I do? So bottom line is, if I've got a patient deteriorating, I don't think that I can prone the patient. I'm just going to go ahead and intubate them. There's a lot more factors than pulmonary physiology, including microthromboses that we see with COVID. Sepsis, perfusion abnormalities is a real problem. And just to make things more unpleasant, many of these patients have acute kidney injury. Now that the patient's on the vent, how the lung response will influence our ventilator mode and setting. On chest x-ray, COVID pneumonia looks a lot like ARDS. It's sort of this diffuse, fluffy, inflammatory infiltrate, primarily out at the periphery. The lung is edematous, it's inefficient, oxygenation is difficult, and alveoli are filling up with fluid. However, the usual ARDS lung, the lung has a low compliance. It's stiff, it's heavy, and the alveoli are closed, and recruitment is a real challenge, which is why very high levels of PEEP are used. In the COVID lung, interestingly, compliance is often good, and recruitment of the alveoli is less arduous, and they respond to PEEP more effectively. And we're going to talk about this a little bit more. And this is just a chest x-ray, normal chest x-ray. And here's what the COVID patient looks like. It looks like sort of an ARDS-ish looking picture. You know, you would almost say maybe congestive heart failure, but you've got very sharp costophrenic angles that you can see here and here. But this fluffiness kind of looks like ARDS, so, but it doesn't act that way. This is a chest x-ray in 2 patients suspected of COVID, both tested positive. this was at a time when the test took about 6 hours and not the rapid test that we have before. This is a little bit more advanced disease, particularly in the patient on the right. You can see that the disease is a little bit worse. These are definitely sicker patients. These are 2 chest x-rays in patients just prior to being intubated. This one on the right, this is a 30-year-old patient who went on not to do very well. CAT scans show a much worse picture. This is the chest x-ray on that, on this patient, and you can see there's a lot more disease than what you might appreciate on the chest x-ray. But we were talking about different lung dynamics. You can see on the CT scan, there's a lot of open lung yet. No, there's a lot of lung involved in disease. You can definitely, particularly as you get lower in the chest and out at the, almost all out at the periphery, but there's a fair amount of lung still left. This is also a patient with rather severe disease. And again, there's a lot of lung that is still functioning and open. And this is a bit different than the ARDS picture. And boy, this looks very much like it. Now that I've mentioned it, ARDS, a whole bunch of times, let me just back up a little bit and talk about what it really is. The Berlin criteria, I think, is the most accepted criteria currently. It has to have all of the following: timing within a week of symptoms. Chest x-ray shows bilateral opacities that you can't explain by anything else, and the respiratory failure is not explained by CHF. Risk factors would include a lung insult like pneumonia, trauma, sepsis, pancreatitis, and we have objective evidence that we've excluded congestive heart failure. The PaO2 FiO2 ratio, I think, is very important and one that I routinely use to judge how sick my patient is. Mild, that ratio is between 200 and 300, going up to severe if it's less than 100. This is more ARDS data, but I am also using it in the COVID patient to kind of judge how sick they are. This is a couple of chest x-rays to just contrast what I've been trying to say about COVID infection and severe ARDS. I mean, if you look at these x-rays, you know, they're pretty similar. I mean, if I looked at this x-ray in a patient I suspected COVID, I would call this COVID right off the bat. Ventilator settings. A lot of controversy between pressure control advocates and volume control. And that basically tells me nobody knows for sure. The challenge with pressure control mode is not being able to control the minute volume. Most intubated patients are intubated for hypoxia, COVID patients. So starting with an FiO2 of 100 is more often the rule. We want to try the lowest possible peak, sort of that gentle ventilation, because basically what we're doing is we're buying time until the lung heals itself. And these patients are remaining intubated for long periods of time, weeks. Many patients are hypertensive, some are not. I always keep a push dose pressor. In our department, we have these pre-filled syringes of phenylephrine that I like to have in my pocket. I carry it around much to the chagrin of my pharmacist, but I like to have it, and I particularly have it in all the patients for COVID infections that I'm intubating. Blood pressure can certainly influence how much PEEP we can use, and keeping the patients deeply sedated is really, really important. So some of the settings that I've used for patients that I've intubated, tidal volume 6 to 8 cc's, like any pressure control mode, I like to use at least starting out. FiO2, more often than not, 100%. PEEP between 16 and 18. I'm trying to take advantage of the fact that I've got some open lung and to keep them open. Respiratory rate between 14 and 16 and an IDE ratio 2 to 1. Soon as I get these patients intubated and secured, then I'm turning and I'm looking at my ventilator. And what I want to monitor is plateau pressure, less than 30, the minute volume of 6 to 7 liters per minute. And I can't figure that out on the ventilator. So I just turn to my respiratory therapist and ask, give me a minute volume. Flow time curve, making sure that the patient isn't initiating the next breath before they fully inhale. ABG sooner than later, certainly within 10 minutes. Look at my chest x-ray. That's going to give me the depth of my endotracheal tube. And prone positioning, to consider if nothing seems to be helping. Frequent reevaluation. This is critical because these patients change their status very rapidly. It reminds me, I can hear Ron Chrome's gravel-like voice, and I can see him standing outside the emergency department and ambulance entrance smoking his larks, and he would often say, when in doubt, it's okay to examine the patient. Well, coming back and re-examining these patients are very, very important, and looking at all the things that we just talked about: plateau pressures, peak pressures, blood pressure, pulse ox, minute ventilation, and checking your ABGs. Keep in mind, small deviations are multiplicative. So a little decrease in pulse ox, a bit of a rise in plateau pressure, a mild increase in respiratory rate can all herald a major negative deterioration of the patient, as opposed to a single parameter that has a large change, like the pulse ox seems to be initially improving and then seems to be worsening. So just keep in mind that, like most critical patients, it's a matter of a little bit. So a little bit of improvement here and there, and a little bit of a deterioration here and there. I want to mention Dr. Gattinoni. He's currently in Germany, but he's an Italian critical care specialist. And he talks about two phenotypes of the COVID lung. He talks about the type L, and that is that patient who has good compliance, low elastance, low P to F ratio, low lung weight, and you don't need to recruit the alveoli because most of them are open. As opposed to a type H patient, which is more like what we're used to with ARDS. They're poorly compliant. They're heavy, wet lung, high right to left shunts, high lung weight, and many of the alveoli have collapsed or are filled with fluid, and so there's high recruitability. Ventilation protocol would substantially differ between these two types. I had a very interesting experience of being able to do a webinar with Dr. Luciano Gattinoni, and he stresses ventilator treatment of COVID patients to be guided by this physiology. And I've actually found that this begins to give me a little better sense of what to do with these patients. In his experience, some 60% of these COVID patients were the type L. They looked like ARDS. The lung was poorly functional. These patients were hard to oxygenate, but they had good compliance and open alveoli and things like that. The issue of deterioration is based on interstitial edema and particularly right to left shunt. So according to Dr. Gattinoni, what he says is the coronavirus, you get the infection, the virus binds to the cell membrane at the ACE and ACE2 inhibitors. This causes a marked inflammatory response. You get interstitial edema, and that causes the ground glass opacity that start in the periphery. The lungs are still primarily air with areas of edema at the periphery, and lung mechanics are still excellent. However, as things progress, you get what he calls a lung vasoplegia, the inability of the lung to exquisitely control where blood is going. So blood goes to where places are ventilated, it's shunted away from places that are not, and the lung really can control this, but it deteriorates markedly with COVID, and that's based on the fact that the virus binds to the ACE2 inhibitor, upsetting that very fine balance between angiotensin 1 and 2. You get an increase in angiotensin 2, you get vasodilatation, you're also getting increased nitric oxide and increased cyclic GMP, and that is increasing edema and just worsening that right to left shunt, meaning that you get unoxygenated blood mixing with oxygenated blood, and the result is a decreased amount of oxygen within the blood. For Dr. Gattinoni, he stressed that the work of breathing is a key clinical parameter that heralds the patient worsening respiratory status, and that has also been my experience. With the worsening of perfusion in the lung that causes the increased right to left shunt, the patient experiences more hypoxia. What do you do when you feel like you're not able to breathe and you're not getting enough oxygen? You increase your work of breathing. The respiratory rate goes up, the use of accessory muscles become more prominent, the patient visibly becomes more uncomfortable. And what's happening is they experience that sensation of dyspnea, so they try to pull in a higher tidal volume. Let's say, just for an example, 600 cc's. But given the lung dynamics that they're working with, they can only pull in 400 cc. So they feel more dyspneic, so they try even harder. They work even harder. The respiratory rate goes up, the accessory muscle use goes up, the patient becomes visibly more uncomfortable. Now things start to deteriorate quickly. And what is the also a result of this increased work of breathing? You get an increased negative pressure because patients are pulling harder. That causes an increase in intrathoracic pressure, a decrease in venous return to the right side of the heart. Cardiac output begins to fall, and it worsens the perfusion of the lung that's already having difficulty managing its blood flow, and this finally results in hypoxic respiratory failure. How we break this cycle is not very clear. We can give the patients oxygen, sometimes this helps and sometimes it doesn't. We closely monitor the respiratory status, and essentially I would say early intubation seems to be what's recommended by most experts, even though some people now question that, but they don't offer what else to do. Other factors that are extant: increased metabolic demand exactly at a time when the body can't meet that metabolic demand, both breathing, cardiac, and renal demands. Thrombosis. We know that there is a microvascular thrombosis process with COVID infection, and it already impairs perfusion, and the role of anticoagulation, not clearly delineated, but most people are recommending if you get to the time where you've intubated the patient, you should anticoagulate them. Renal failure and AKI play a role, and COVID patients tend not to need a lot of fluids, and it's not recommended that you give them the 30 cc per kilogram bolus that you are with usual septic patients. Inflammation with elevation of all kinds of markers: procal, ferritin, IL-2C, RP, ESR, and how that guides therapy and initiation of antibiotics and steroid use, not quite as firmly delineated as I would like. We do know that from sepsis data, and we are definitely seeing it in COVID patients, there are certain patients who are genetically predisposed to a massive hyperinflammatory response. We see that with the coronavirus, but how to identify these patients in time to intervene remains unknown. And this is also called the cytokine storm. To assess the lung, Dr. Gadnoni in that webinar said, look at the work of breathing, CT scan of the chest, you saw the difference in that. He also uses esophageal chest pressure and chest wall EMG. I don't have access to that. So basically, what I look for most of all is the patient's work of breathing, and I have a very low threshold of getting CT scans, and that helps me a lot. In this slide, we can see two CT scans, both of COVID patients. The one on the left, this is a type L patient. The lung is fairly compliant. A lot of the lung is still open. They respond relatively well to PEEP. The right hand, this is a type H patient. This is a very heavy, non-compliant lung that is stiff and edematous. You can see that patients change. These are 3 CT scans, interestingly enough, that they did one each day on a patient who is intubated. And on day 1, once again, you can see a lot of open lung, a lot of diseased lung, and as it progresses, this patient goes from a type L patient to a type H patient, and this is the chest x-ray. You can see that the patient's already is intubated. This is day 3. They've gone from L to H, and the ventilatory strategies between these patients has got to change with the status of the patient. For Dr. Gadnoni, his recommendations for ventilation of the type L lung: VC mode, tidal volume 8 cc's per kilogram, ideal body weight. What he wants to do is have enough tidal volume to keep those alveoli open, and he doesn't want them opening and closing, and that can lead to ventilator lung injury. FiO2 is needed, but often is 100%, respiratory rate of 14, and PEEP, in these patients, he starts low and moves up as needed, hoping for a maximum of 15. In the type H lung, it's more classic ARDS. He again uses a VC mode, but he lowers the tidal volume to 6 cc's per kilogram ideal body weight, and FiO2 to keep SATs at least 92%. You don't have to go above that. A respiratory rate to keep the PCO2 less than 60, but will accept up to 60, and PEEP less than 15 centimeters if possible. I use the ARDSNet protocol in this type of patient, and I have definitely gone over PEEPs of 15 or more. And this is the ARDSNet. It talks about two patients, types of patients, the ones with lower PEEP and higher PEEP. I'm ending up more often than not, if I've gotten to this point, in the high PEEP patient. And you see if you're at 100% FiO2, you're going to be PEEPs as high as 22 and 24 centimeters of water. Dexamethasone. This is also new data. This came out and was reported 6/16/20. This was the results in Britain of what was called the recovery trial, the random evaluation of COVID-19. And what they found is that mortality was reduced by 1/3 in ventilator patients given 6 milligrams of dexamethasone every day times 10 days. That gave a NNT of 10, a number needed to treat of 10. It also lowered the mortality in patients who required oxygen, but not to the point of ventilation, with a reduction in mortality of 1/5. In patients who were holding their own and did not require ventilatory support, the dexamethasone did not make a difference. In the words of the one of the chief investigators, Dr. Horby, dexamethasone is the first drug to improve survival in COVID-19 and is an extremely welcome result. And I've given the citations here if you want to look them up. So in summary, treatment of the COVID lung is difficult, with rapid change in respiratory status the norm as opposed to exception. Check your patients frequently. And understanding of some of the pathophysiology can allow you to anticipate the patients at risk. The obese patient, the patient who might possibly have a VTE, the patient who has concomitant diseases. Oxygenation options, nasal cannula, high flow nasal cannula, non-rebreather, bag valve mask. I didn't mention CPAP just because I don't have it. I just have BiPAP, and that's open to the air, so we don't use it. The intubation sequence stresses avoiding splattering secretions and protecting the intubator with meticulous PPE, the use of video laryngoscopy, viral filters, and clamping the endotracheal tube to avoid having it open to the air. The pathophysiology seems to be a unique inflammatory response that in the end impairs the lungs' ability to manage perfusion. As respiratory function deteriorates, the patient becomes more hypoxic and the work of breathing becomes greater, and this is often very evident at the bedside. The result is high intrathoracic pressures, which just further exacerbates this perfusion problem because it reduces venous return to the heart, reducing cardiac output on the right side, which reduces cardiac output on the left side, and blood pressure tends and perfusion fails. Deterioration tends to happen quickly. Ventilatory management has advocates of both VC and PC, which tells you modes, tells you nobody is really sure. Clearly, the COVID lung, while often showing you radiologic signs of ARDS, is different in that you have this type L patient lung with higher compliance, responds to PEEP differently than the traditional ARDS lung, which is more like the type H, that is heavy, edematous, stiff, and many of the alveoli are offline. The patient's work of breathing is one of the best parameters to measure. CT scanning can really help as well, and it also lets you know whether the patient has a pulmonary embolus. In the words of Dr. Gadanoni, patience is likely the best thing we have to offer our patients. They remain intubated for very, very long periods of time, and so patience is a key. Dr. Alvarez at the University of Miami notes, ventilator is a supportive measure while we wait for the patient's body to recover. So, in the end, stay safe. Keep yourself physically and mentally well. Tell those that are close to you you love them. We don't say that enough. Cherish those that you work with. It's been said in the media and elsewhere that you are heroes, and that is exactly, in fact, the case. Many people had, and physicians had the option to avoid this whole pandemic, but that's not in the DNA of emergency physicians, and there's grace and courage in that. This is just for your reference. This is our protocol that we use. And Winston over here, he's the official mascot of the Michigan College. And both of us say, stay well, be vigilant, and be careful out there. And I will be glad to entertain any questions. And there's my email address should anybody want to get in touch with me. So if you want to unmute yourselves, everybody's been so good about that. Anybody have any questions? I'm here to try to answer them as best I can. And I thank you very much. I'm really honored to be able to do this. I hope you enjoyed it. No questions? Well, then I will wish everybody. Oh, I'm sorry.
Hi, Dr. Walters. It's Amanda Amen.
Oh, hi, Amanda. How are you?
Good.
Amanda, for those of you who may not know, she's a brand new MD. She has now graduated from OUWB, and she's one of my mentees. She's really stellar and outstanding.
Thanks, Dr. Walters.
And of course, she's not coming to Beaumont, breaking my heart. Thank you, Amanda.
Sorry. Actually, tuning in from LA. But of course, any chance I can do or have to get a talk in is great. So my question is, one, as far as the H and L types, are you determining that radiologically or clinically as you're first setting up your vent settings and seeing how they respond?
No, it's a little hard. To some extent, I'm looking at it radiologically. It is a lot easier to do that on a CAT scan than a chest x-ray, but the chest x-ray is going to be much denser on the type H patient. I may also, once I've got them intubated, looking at their plateau pressures. In fact, I can actually feel it when I bag the patient. You know, how hard I'm squeezing the bag can be a helpful determinant. But the chest x-ray and the CT scan are the primary ways I can differentiate an L and an H.
Okay, great.
Does that answer your question?
Yeah, definitely. And then second question, as far as, you know, as a new intern myself, are you having your junior residents and your interns intubate, or is this something as far as just like what your protocols are and who you're comfortable
All right, that's a great question. All right, and we had a lot of debate. As the Airway guy, in my department, and my residents say that, you know, I'll intubate anybody who won't crawl away from me fast enough, and I resent that because I can definitely intubate some people who are crawling away from me. You know, I'm fast enough. We took the position that all the intubations when we were in the midst of the COVID crisis are going to be done by anesthesia. So prior to that, anesthesia would come down to our department only if we called them, if we had a particularly bad airway or difficulty intubating the patient, which was not very common. We're pretty good at what we do. All the data shows that emergency physicians are very good at airway management, intubation, and running vents. Just for safety purposes and to have a single group that was familiar with the protocol intubate, we were calling anesthesia down. We are no longer doing that. Now, if there's a second wave and this happens, we probably will reinitiate that process, but not all hospitals have that option. And there were more than a few times that even in the midst of it, anesthesia just couldn't respond. They were responding to 2 or 3 different patients who were deteriorating all at the same time, and then the emergency department calls. So emergency physicians have to be facile in being able to manage these patients safely, both for the patient's sake as well as their own sake and their personnel's sake. So emergency physicians still have to be the people who know and can manage airways the best in the emergency department. And whether in terms of who did it. We debated that quite a bit, but we relegated it to third-year residents. Again, just to lessen exposure. Okay, so I suspect that because you're going to a hotspot state, they will probably not have you intubate the obvious COVID patient, at least initially. You're already a pretty good intubator anyway. Any other questions?
Sure, I have a question.
Can you just speak up? I'm not. You're not coming through very well. Hello?
Any better?
Yeah, much better.
Okay. Well, first of all, thank you for this presentation. It's been really helpful just to hear, from another expert out there as to what your practice is.
I don't know if I'm an expert, but but thank you. Those are very kind words.
I just wanted to ask about the CPAP versus BiPAP.
Right.
They both, I would have thought, kind of looked like closed circuits. Are we saying that BiPAP is not a closed circuit because of the leak from the mask?
At least at Beaumont.
Ah.
The way our BiPAP is, it is an open circuit. And we can't close the circuit, but we could close it with CPAP. It's just not as available in our department. So we did not BiPAP patients. That was debated, and there were all kinds of jury-rig, MacGyver kinds of devices to kind of connect the viral filter, and so on and so forth. So bottom line is we've just avoided BiPAP, which is a real disadvantage because non-invasive ventilation can really be not only helpful to pre-oxygenate your patient, it may stave off intubation altogether. For some devices, I believe Scott Weingart on MCRIT and Rebel EM had some suggestions of kind of jerry-rigging a BiPAP to a closed circuit kind of thing. We just avoided the issue by just saying, hey, listen, nasal cannula to non-rebreather to non-rebreather post-nasal cannula to bag valve mask in preparation to intubate your patient. If they fail those things, you're just intubating them.
Okay. So would I be able to know if the circuit is open or closed just from looking at it? Because I don't know what yours look like.
I don't know, but this is where my respiratory therapist really, really helped me. And in my department and looking at our device, it was very obvious it was open because the patients exhale through an open circuit.
Okay.
All right, and it didn't have a nice connector where we could not only connect the viral filter, but then we could then connect a hose to the viral filter back to something. So it just was the mechanics of the device we used and we have available, and so we just decided to eliminate it from our options. So, but your respiratory therapist should be able to help you with that, and you can examine where the air goes in and the air goes out, and you should be able to figure out that whether it's open or closed.
Okay, thank you so much.
Oh, my pleasure. Other questions? Well, with that, I just wish you all the very best. Please email me. If you have any questions you think of, or if you've got some suggestions or experiences. I just want to point out that the picture that you're seeing of Winston, he is sitting in the chair of the executive director in her office at MSEP, which he considers that his chair. And with that, I will say good night to everybody. And thank you so much.
Thank you, Brad.
My pleasure. Thanks, Paul.
Thank you, Dr. Walters.
Oh, thanks, Maddie.